Dear audience, my name is Eszter Szalai. I am from Conservative Department. We will be a bit more familiar today with my PhD topic, investigations of halitosis. My vision is to find and bring the best solution for diagnostic and managing halitosis to everyone. And my mission is to raise the concern of science and the public about bad breath leading to better prevention and treatment of halitosis, terribly improving patients' well-being. These are my first steps how I would like to achieve my vision. My first project is a systematic review and meta-analysis. The topic is the investigation, the efficacy of chlorine dioxide in halitosis. 60% of the world population has experienced halitosis. Most of the cases are originated from the oral cavity. It means that the people can't eliminate the volatile sulfur compounds producing bacteria with a simple toothbrush. So they spend billions of dollars a year on anti-malodor mouth rinses, as we can see on the picture, but they still don't know which is the best. Chlorhexidine containing mouthwashes seem the gold standard, but they have side effects, for example, tooth and tongue staining, dry mouth, false taste sensation, and so on. So, our aim to evidence the effectiveness of chlorine dioxide in halitosis. Our clinical question is, how do chlorine dioxide containing mouthwashes influence the level of halitosis? P is the patient with bad breath. E is the chlorine dioxide containing mouthwashes, the comparator, the placebo or other mouthwashes, and the outcomes, the primary outcomes, is the changes in the organoleptic testing or in the volatile sulfur compounds. The organoleptic testing means that the tester smells the patient's breath and after that evaluate it. Our hypothesis, the chlorine dioxide containing mouthwashes as efficient as other mouthwashes or more efficient. The clinical implication is that it can be the first choice both of the dentist and patients for halitosis. After our systematic search and our selection process, we found 8 eligible full texts. Here we can see the results. The first forest plots show the changes in the organoleptic testing source. As the data, as the forest plots show us, the chlorine dioxide containing mouth rinses are effective in a 1 day, 1 week, and a 2-week data. The comparator group was the placebo. These forest plots show us the volatile sulfur compound changes in the 1-day data. We can see that the most effectively reuse the chlorine dioxide containing mouthwashes, the hydrogen sulfide parts. The strengths of our meta-analysis, the strong mathematical results, the organoleptic measurements in more time point, and all of the studies were RCTs, and the limitations are the small number of studies, and further studies need to detect the difference with other mouthwashes, because most of the cases the comparator were placebo, and just we found one article with a comparator chlorhexidine, and we can see in the table that chlorine dioxide containing mouthwash was as effective, almost as the chlorhexidine, as what is the gold standard. Other limitation is that we couldn't make a meta-analysis from the total volatile sulfur compounds data because the results weren't comparable, so that gave the idea for us to make a second meta-analysis. Implications for practice, chlorine dioxide containing mouthwash is an effective mouthwash in halitosis without side effects, more effective than generally used mouthwashes. Implications for research, helps to facilitate more investigations between chlorine dioxide containing mouthwashes and chlorhexidine containing mouthwashes. My second topic is also a systematic review and meta-analysis. Effectiveness of halitosis measuring devices compared to the organoleptic testing. As we saw, the most used diagnostic methods of halitosis is the organoleptic measurements. This is the gold standard, easy to perform, but subjective and unreliable. uncomfortable for the tester and the testee. Other methods, the oral malodor measuring devices, they are subjective, the results repeatable and reproducible. We know more type of devices, for example, the portable volatile solvent compounds monitor, the halimeter, the portable gas chromatograph, for example, the oral chroma, or the e-nose system. So the problem is that we couldn't couldn't compare the results for each other, so our aim to standardize protocol for the clinical research into oral malodor. The clinical question is, to what extent are halitosis measuring devices valuable for clinical diagnosis compared to the organoleptic testing methods? P is the healthy population, I is the oral malodor measuring devices, the comparator, the organoleptic measurement, or primary outcome, the correlation coefficient, and the secondary is the feasibility of the devices. Or hypothesis, the halitosis measuring devices as appropriate as organoleptic method, the measure the level of halitosis. So I truly hope that after the results we can suggest a device that will make shorter examination time and more effective studies. It is our systematic search, and I will plan my 2 meta-analyses finished next summer. And the first and greatest victory is Conquer Yourself from Plato. Thank you for your attention.
So can you tell what would be the range of these organoleptic measurements between the examiners? Is there a widespread when different examiners are evaluating the same patients?
It depends on the trial, but usually they give from 0 to 5. But if there is more judges, they make a correlation between the judges, and after that they can measure that how effective the measuring.
Why do we have to measure actually halitosis? What will be the clinical benefit, or what can we do with that? If we measure it with devices, maybe we can say that where from originated, because if it originated from the oral cavity, it's easier to cure that. If it originated from it's related from other systematic diseases, we can cure it in other ways. So you're also measuring the quality, or how to call it?
With the devices, we can measure the quality also.
I understand. Okay, thank you very much.
I would like to ask the question regarding the PICO. So for the patient, did you put some exclusion criteria? Because the bad breath has a lot of reasons. So if patient has some kind of chronic disease, so how does it differ from?
Yes, we exclude the patient with systematic disorders.